morning. Thank you very much for the invite. Thank you, my brother, Dr. Abdullah, for giving me the opportunity to be part of this very interesting meeting. So I'm going to try and talk about what's new in the management of atrial fibrillation. So the objectives of my talk are going to be to demonstrate the latest evidence on rhythm control versus rate control in atrial fibrillation management, demonstrate few important concepts in the management of atrial fibrillation, and demonstrate the impact of the recent evidence that we have on the guidelines. So I'm going to start with a quick introduction, the important concept on atrial fibrillation, some important clarifications in atrial fibrillation, rate versus rhythm control, and the evidence that we have, the available strategies, especially a special focus on the pulse field ablation. It's the most recent and advanced technique that we have in the ablation of atrial fibrillation, and few take-home points. So as we all know, atrial fibrillation is a supraventricular tachycardia characterized by the uncoordinated atrial activation, leading to atrial remodeling and going through phases of the atrial remodeling. So the first phase, which happens quite quickly, is the electrical remodeling that happens in the atrium. And that's mainly the shortening of the refractory periods of the atrial tissue, leading to more sustaining of the atrial fibrillation itself. The second stage would be the contractile remodeling, where due to the very fast activation of the atrial tissue, the muscle is actually losing its ability to contract. And that sets the stage to the structural remodeling, where the structure of the atrium is actually changing and the atria is dilating and getting more fibrous. It's the most common sustained cardiac rhythm disturbance in adults, and the hemodynamic impairments and thromboembolic events related to atrial fibrillation results in significant mortality and morbidity. So I think the first important concept in atrial fibrillation that we started realizing more and more is that atrial fibrillation is a very complex disease. Now, in Europe, you see teams taking care of patients with atrial fibrillation rather than just a single person. It's not a one-man show controlling atrial fibrillation. Like, you have so many modifiable risk factors. Of course, there are the unmodifiable risk factors, but there are so many modifiable risk factors that can impact the outcome of atrial fibrillation, especially when you try to go for a rhythm control strategy. All these will play a role in the outcome of your management for the atrial fibrillation. So the better control you have on the other risk factors, something like hypertension, diabetes, weight reduction, obstructive sleep apnea, these will have a huge impact on the outcome of your procedure. So I've chosen to take this patient for atrial fibrillation ablation. So you need to understand that taking care of a patient with atrial fibrillation is never a single-man show. The second important concept is the progression in atrial fibrillation. It's a very progressive disease, and it changes actually with time. Like, the later you deal with the atrial fibrillation patient, the more complex the disease has become. So at the initial phases, where the atrial fibrillation is still in the paroxysmal stage, you're dealing mainly with triggers coming from the pulmonary veins. It's an ectopic foci that are triggering the atrial fibrillation. So when you take a patient in this very early stage, the impact on the atrial fibrillation is going to be huge, because you're actually preventing the triggers. However, as the time progresses and we're changing to a persistent and even longer-standing persistent, and at later stage, a permanent stage, you have multiple circuits of re-entry due to the structural remodeling that happening in the atrium. So you can imagine, if I caught a patient where the atrial fibrillation is being triggered by something from the pulmonary vein, my atrial fibrillation ablation is going to be super effective. Where if you're dealing with a patient where the trigger is coming from multiple areas, sometimes it's in the right atrium, sometimes in the left atrium, isolating only the pulmonary veins is going to be as effective. So it's really important, and we have more and more evidence that the earlier you handle these patients, the better your long-term outcome. So I know this goes to way too long now, but it keeps coming in each and every single meeting. That's why I keep showing people the FM trial, and everybody is telling me rate versus rhythm control is not really different. This has been studied before, but I think we need to update ourselves because the FM is almost it's more than 20 years now. So when we see the results from the AFFIRM trial and showing no real difference in mortality, I think we need to go a little bit in the details of the study. So in the AFFIRM trial, we didn't have any potent mechanism or potent technique to control atrial fibrillation except the medications. And we all know whatever benefit that we gained from maintaining these patients in sinus rhythm was counteracted by the side effects that we get from the antiarrhythmic medications. So we all know from very old trials like the CAST trial that the antiarrhythmic medications, they can actually increase mortality in certain subgroups. So having only medication in this study was one major flaw. And then this study was analyzed as an intention to treat. And when we did secondary analysis in patients who actually remained in sinus rhythm, I just need to highlight that the people that remained in sinus rhythm were not more than 40% in the treatment group. So 60% of the people who were analyzed as a sinus rhythm or rhythm control were actually in atrial fibrillation by the end of the study. So this has also impacted the results. So again and again, please, when you talk about the AFFIRM trial, one, it's a very old trial. Two, I know it was an intention to treat, but please remember that's only 60%. And this we have seen in so many trials right now. Only 60% remained, only 40% remained in sinus rhythm at the end of the study and at the time of analysis. So it was a somewhat and not a very accurate study. So this was counteracted, I think, with the eSafeNet 4, where they did something that we called early rhythm control, which is super important. And we base it already on one of the important concepts that we did. So these patients were diagnosed with atrial fibrillation in less than a year. And they managed to, a good percentage of them, almost 20%, actually underwent ablation. So by the time of the analysis, around 70% of the patients were actually in sinus rhythm, which is very different to what we had in the AFFIRM trial. So definitely you would have a significant impact. So this study actually showed that there's a significant reduction in mortality and in stroke recurrences of atrial fibrillation, because these patients actually stayed in sinus rhythm by the time of the end of analysis. So it's super important to focus that these patients were controlled, but they were controlled early compared to the older trials. Just wanted to highlight two very interesting studies. Early AF and progressive AF, both showing superiority of ablation compared to medication when we're talking about control or a rhythm control strategy. And I think this graph we've seen in so many trials right now. Like at best, your medication is gonna keep your patients or 40% of your patients in normal sinus rhythm as time passes by, compared to almost 70% at 1 year, depending on which trial and which technique that you're talking about, but almost 70% versus 40%, even when you're using potent drugs like amiodarone. So we know for a fact right now that ablation is actually superior as a rhythm control strategy. So the summary of the atrial fibrillation ablations trials that we have, we know that the impact is going to be higher if the patient is symptomatic, if he has a lower quality of life, heart failure, high atrial fibrillation burden, and a younger patient, compared to a patient who's elderly, asymptomatic, no comorbids, and no very low atrial fibrillation burden. You know that we can actually improve their heart failure, left ventricular ejection fraction. We can lower their mortality. We can target PVIs. Cafes and lines, I would say, are becoming less and less popular. So it does actually improve their quality of life when we keep them in normal sinus rhythm. The techniques that we have are radio frequency, cryoablation, and most recently we added pulmonary pulse field ablation. So as we said, we have two strategies, medications versus catheter ablation. Of course, we have the surgical and the hybrid techniques, but this is not in the scope of my talk today. So the drug therapy, you guys all know them. But I thought what was interesting in the guidelines is that you always have a patient choice of going directly to catheter ablation and bypassing the medications. So after discussing with the patient, especially in a paroxysmal patient, it's a class 2A indication to go for ablation directly. And I think in the upcoming updates and the guidelines, I think it's going to be even more enforced, like controlling these patients, especially the paroxysmal symptomatic patients when they're young. I think we're going to see more and more influence or more and more support from the guidelines to go directly to the atrial fibrillation ablation rather than putting these patients on medications. So when we're dealing with symptomatic atrial fibrillation, of course, if it's paroxysmal, you have a class 2A to go directly for atrial fibrillation ablation, of course, after discussion with the patient. It's persistent atrial fibrillation without major risk factors, a class 2A, and definitely on patients with heart failure, it's a class 1 to offer them these patients ablation. So we talked a lot about radiofrequency cryoablations before, but even yesterday we were in a training course for the pulse field ablation. It's actually is a very impressive technique. It brought down the time for the atrial fibrillation procedure to nothing more than 30 minutes, 40 minutes if it's a complex case. And I think it's going to change the way we're or going to change the limits on age that we're dealing for these patients. Most teams, especially with the radio frequency, they're going to shy away from very elderly patients. But I think with pulse field ablation, this is going to change slowly. So what's the pulse fields? It's a non-thermal, no heating or cooling ablation therapy. It's based on the irreversible electroporation using a strong electrical field that would disturb the cell wall, but at the same time maintaining the matrix of the tissue. So, and you can actually target specifically the myocytes. So this treatment does not affect any adjacent tissue. You're just tackling the atrial myocytes actually when you're dealing with the pulse field ablation. For the time being, it's only approved for the paroxysmal atrial fibrillation, but we're seeing more and more teams are using it for persistent atrial fibrillation patients. So as you can see here in this slide, you're not worried about damaging the esophagus or damaging the phrenic nerve because you have no impact on them at all. There are only few reported cases, I think, of coronary spasms, especially when you're not dealing with the veins only. These, you started seeing them when people were using it on the mitral annulus, for example, isolation. And you started seeing like coronary spasm, but almost all cases, they were reversible. They didn't need the stenting, they didn't need anything, just some nitrates, and the issue was resolved. So who's the ideal ATF ablation patient to refer to electrophysiologist? I would say ideally patients who are younger than 75. And this statement is based on the Cabana trial where they showed clearly if you're dealing with a patient that is above 75, there's a slight, it was a clinically not significant, like the P value wasn't significant, but they had a higher rate of mortality in this and higher rate of complications in this population. Mainly it was radio frequency, it wasn't even cryo, mainly the Cabana trial, but due to that fact, I normally like to see patients who are below 75. Of course, as I said, with the pulse field ablation, I think our threshold might be slightly changed. As we say, paroxysmal ATF ablation who are highly symptomatic with controlled risk factors, because so many studies have shown right now, even with the ablation for ATF ablation patients, you can actually have a better outcome when the patient is well controlled. I mean, risk factor wise. If you have a tachycardia-induced cardiomyopathy, definitely it's a class 1 indication. If you have heart failure, the atrium is not severely dilated, and of course, the patient is willing to have the ablation. So my conclusion, ATF ablation is a multifactorial disease in which controlling risk factors is actually cardinal and super important. So maintaining sinus rhythm has more and more evidence for superiority to rate control. Catheter ablation is superior to antiarrhythmic medication for maintaining normal sinus rhythm. Multiple studies has already shown this. Early referral for ablation is linked to a better long-term result. I would quote Dr. Luigi Dubiase. I love his saying. When you have a patient with ATF ablation, intervene early, and intervene early with ablation rather than with medications. Thank you very much.